So, very good evening. We'll come back to the second part of maternal medicine in MRCP. As I told last time also, let me tell you again. This maternal medicine, basically, few questions are come from the maternal medicine. Basically, this is a part one topic, but there are some questions also will come part two. You will find out that there are questions are coming in different sections like cardiology, neurology, ID, which is related to the maternal medicine, and they come in any section of the uh, questions, but they are related to the maternal medicine topic, and you will be able to answer it if you know the core concepts. Before I would start, I would like to tell you that I was asked to take some of the recap classes for last week, so I will go through few of the topics which will seems to be repetition for some of you, but this is what because of some technical glitches I was told to do that. And before I proceed to the next slide, I would like to request to all of you that please raise your hand or send some questions in the chat box what you want to ask, because if in between you stop it, that will be difficult. And the most important topic and questions is that this class is based on basically Royal College guidelines to write Royal College exam. If don't get confused with the Southern Asia or subcontinental or to specific India or particular state guidelines, this will only not only complicate you, but also it is also make you difficult to answer in the exams. So, and most important thing, we will be not able to discuss that much detail in the physiology of each topic because that's beyond the scope of this class. But if you have any questions, you put it back. I will jot down and try to answer today last, or maybe I will do in the next classes. In between, if you have a question, please do let me know. Without taking much space time, we'll move it to the next slides. And with that, why pregnancy is so different, all of you, as I discussed in the last time, there will be changes in the body from all aspects, from the respiratory, from brain to thyroid to GI to cardiovascular to renal to hormone and hematological. And this is why, keep it in back, we will have to start the next sessions. So give me a moment. So if you're able to see the questions, we'll start with the question. So this 30 years old lady pregnant with unilateral leg swelling with a pain and with the Doppler shows a DVT. What is the next step of management? How do you do that? So usually we have to start a anticoagulant without investigating further. Next question. Similarly, this 24 years old lady, which is having a suspected pulmonary embolism, after discussing with the patients and patient's family, we wanted to do scan. Which one used to do, CTPA or VQ scan? So the answer should be there that CTPA has to be done, and it has a more maternal breast cancer risk. Now, if you understand these questions, we will move it to that why pregnancy and DVT is little different. First of all, if you go through the list of in the well score, you understand that this pregnancy one of the risk factor for having DVT. That because pregnancy is a hypercoagulable state and basically everything happen in the last trimester. What is the pathophysiology to have that? Because there is increased factor of factor 8, factor 7, factor 10 and fibrinogen, and decrease of protein S. This is the main reason for having the more prone patients develop for DVT. And also there is uterus, which is caused the compression of the gravity uterus in the inferior vena cava, which is caused the venous status. If you clearly remember the virtuous triad, all those things can cause prone to having patients DVT. And how do you manage it? Warfarin is contraindicated. You have to go for small molecule, subcutaneous low molecular heparin, which is preferred over the IV heparin because of the less bleeding and the thrombocytopenia. Basically, it can less chance of hit. These questions are predominantly asked in part 1, but questions can sometimes come in the part 2 also. Let's see more precisely that what all the investigation you have to do. As I told you previously, we are not going to each and every detail. Basically exam focused class. So you have to know that what all has to be done clearly. So you will get the questions like this: when you are suspected a DVT, what your supposed investigation you supposed to do? First, you have to do the compression duplex ultrasound should be taken if there is a clinical suspicion of DVT. And how do you suspect the clinical suspicion? You have to go for the well scored for the DVT. Please keep it in mind. All the patients which were suspected pulmonary embolism has to be done ECG and chest X-ray. Please remember, this is a very statement that we always consider mother is our patient. The kid which is yet to born or still unborn is not our patient. So our primary goal of safety is look like a chest X. Do the take care of the mother. For that, keeping in mind, doing chest X-ray may be theoretical harmful for the baby, but we have to get it done. And this is remain correct in the real life as well as this remain correct in the exams also. Now, if you have a patient who are having symptoms of DVT, you can first do the lower limb Doppler or compression ultrasound, which is showing confirm the DVT. Then you don't have to do any more investigation and proceed for the pulmonary embolism or DVT screening. If the patient suspected, like a patient having hypotension, tachycardia, RV strain kind of feature in ECG, all those features, if you there you find out and your well score is matching based on the pregnancy being the one of the cause factor, you see the lower limb Doppler, you can proceed for the treatment of pulmonary embolism. No more investigation done. Please remember these points very carefully. If your lower limb Doppler showing DVT, you don't have to do CTPA or VQ if your pulmonary embolism suspicion is quite high. The exam has been tricked multiple times, in particular in part 1 on these lines, and it has been taken. Now, whether you have to do to prove CTPA or VQ mismatch, it has to be done in the local protocol as well as discussing with the patients as well as the radiologist. So in NHS is very clear in one part, you have to discuss everything or anything to the patients in detail, the language which he or she understand. You have to convey all the risk factors, even if the chances are less than 1%, you have to convey to them. And this is the main motto of NHS taking this exam, to make you aware of that you have to tell these things to the patients. Now, whether you to do CTPA, yes, CTPA being a more specific, if the patient's kidney function is being normal, you can do CTPA, but you remember you have to explain that there is a little bit lifetime risk of breast cancer because the breast tissue being very sensitive during pregnancy has more particularly effect of the radiation can be prone to them for having more signs of breast cancer. Now, move to the next, whether we have to do the VQ scanning or not. This also has to be discussed with the patient's family and the patient, that this increase the theoretical risk of childhood cancer compared to CTPA. So if the patient's going to take CTPA or VQ mismatch, this based on these points, you have to explain to the patient family. And this has been multiple times asked in questions, that what to explain in different forms. So to please remember these points. And they will try to trick you that whether D dimer has any value. Please remember. Yes. Yes. Yeah. Please remember the D dimer has no value in the patient pregnancy with suspecting thromboembolism. Now, keeping in back of your mind, this is gone for the DVT. I would also like you to empathize few more points, which is very important when you are treating a patients or getting. There are always. Yes.
Sir, excuse me. Sir, what's the well score? Well score to diagnose the DVT in pregnancy. The scoring system.
There are no the well score. There is no separate well score for particularly diagnosis for DVT. The well score which you normally develop, I'm sure you have taken cardiology class and where you got the different component of the well score. It's remained like a all the components is there, but the pregnancy and hypercoagulable is the one of the part of the well score. There is no separate entity for DVT for well scoring, particularly for pregnancy. But there are
Okay, sir.
two types of well score, one for the pregnancy, one for the pulmonary embolism. That you have to remember the components only. Okay. Okay.
Okay, okay, sir.
Yeah, yeah, no
Thank you, sir.
problem. Yeah, sure. So now keeping that, you see, there are a lot of other things that I'm not put in detail that how to thrombolize, what all the topic to be giving in thrombolize, if the patient pregnancy, because these are not very much common in asking exam questions. The other criteria remain almost same in DVT, but these are the particularly which is much more differ from in pregnant lady who is getting a DVT and pulmonary embolism, in aspect of your level in exam to clear Royal College exams. Now, when you are going to get the, am I audible now?
Yes, sir. Yes, sir.
Yes, sir.
Okay, okay.
Your speaker was muted.
I don't know. Somebody got muted. Okay. So as I was telling that, like how you get the NHS like DVLA, you will also get sometime like how this when to give fitness to fly. So we will see each and disease, including the pregnancy. The question has been multiple times asked. So when you get a patient with, suppose it's a cardiovascular, you have an unstable angina or uncontrolled hypertension or uncontrolled cardiac arrhythmias or decompensated heart failure or severe symptomatic valvular heart disease, they are advised not to fly. It's a, their guidelines are very clear, and if you are working as a registrar or specialist registrar in NHS, this kind of patients will frequently come to you, and you have to be certified that. So it is not only important if you're going to practice in UK to how to practice, how to prescribe it or practice it there. It is also exam oriented questions also. Next is that if you have an uncomplicated myocardial infarction, the usually time to 7 to 10 days. If you have a complicated myocardial infarction, the time is 4 to 6 weeks. Please remember all the values. This is unfortunately part of the questions where you have no other part other than have to use your brain to mug it up and get. The artificial intelligence won't help you here. So next question is that if you have a coronary artery bypass grafting, you have to do it almost 2 weeks, 10 to 14 days. To keep 10 to 14 days, you have to fly after the 10 to 14 days. If you have a PCA done or PCI done, percutaneous angiogram, after 5 days, you can fly. If you have a stroke, which advised to wait 10 days following event, if you're very stable, you can even carry it out within 3 days or 72 hours of the event. So very important points. All these things you have no other option to have to remember before the exams. If you go to the respiratory systems, you in case of pneumonia, it should be clinically improved. This is more controversial and most important that the patient is having pneumothorax, whether it's a spontaneous pneumothorax or patient have a complicated pneumothorax, you have the absolute contraindication to fly. But if you have a drainage done after 2 weeks, if there is no residual air in the chest X-ray, you can fly. Still, there are some controversy between the British Thoracic Society and as well as the the guidelines currently coming, but they were recommended that not to fly with up to 6 weeks. But recently they have changed the guideline and making that you can fly after 1 week of post check X-ray. So please remember these points because they will be keep asking these changes from questions. So now we can fly after 1 week of post check X-ray, equally important. And now here come the pregnancy. They will, if pregnancy is more than 36 weeks, you are not supposed to fly. And after 32 weeks with multiple pregnancy, they will be not allowed to fly. And if you are flying after 20 weeks, they will need to have a NORM certificate from a registered physician to have whether you can fly or not. So this is the part which is multiple times asked basically in the part 1, and you have to remember all those things, no other options. Now there is a lot of questions. Basically, this is come in part 1, and this is very easy. You have been studying in your second professional MBBS days that what all the medication you should not practice in given in the pregnancy. There are a lot of guidelines there. There are a lot of drugs is there which can be given, which cautions, which cannot be given. So here we are going to tell you basic drugs which has multiple times asked in questions in different groups to just to remember. Rest of the things there are a lot of we cannot discuss here. So the tetracycline, aminoglycosate, sulfonamides, trimethoprim, and quinolones are completely avoided in the patients in a pregnant lady. Another drug like AC inhibitor, ARBs, statin, warfarin, sulfonylurea, retinoids, and all cytotoxic drugs are completely avoided during pregnancy. Please remember, like that way, majority of anti-epileptic drugs like valproate, phenytoin, carbamazepine are potential harmful, and however, you have to balance a sensible balance. So, but this AEDs or anti-epileptic drugs, we will discuss in the end of the topic, like how to prescribe anti-epileptic drug in a pregnant lady. But for timing, you remember this that the drug should be avoided in a pregnancy. So keeping that in mind, we'll move to the next topic, the GI topic, like that. This is equally important, and let's see how you're going to treat with this kind of patients. So this 28 years old, 32 weeks pregnant lady come with intense itching, particularly her palm, soles, her liver function test is showing ALT little bit high, bilirubin level, but there is no signs of liver failure. What are the most common appropriate management and key complication to monitor for this? So if you understand, can anybody tell that what it is? Yes? Okay. We'll discuss as time comes. Okay. The next question is that this is 34 years week, pregnant 30 years lady, admitted with nausea, vomiting, abdominal pain, is hypoglycemic, her liver enzymes are showing ALT of 720. So what is the most crucial management step? Differentiate between acute liver, fatty liver of pregnancy or ICP. So supportive care. This is you are supposed to answer. 35 weeks of gestation, 32 years lady, upper quadrant pain, nausea, blood pressure is 160, 110, lab showing hemolysis, elevated liver enzyme, thrombocytopenia. What is the most likely condition and how do you manage
HELP
these patients and what diagnosis?
HELP syndrome.
I was expecting
HELP
that
syndrome.
because yes, yes, yes. This is what people will always answer, but you have to know the other points only. Let's see what happened. So that first question was there for intrahepatic ICP, not in intracranial pressure. It is intrahepatic cholestasis of pregnancy, also known as the obstetric cholestasis. Very important point. You have to keep it in mind, and this is not very uncommon. Almost 1% of pregnancy will have this kind of issues, particularly given in the last trimester or third trimester. And this is the one of the most common liver disease which patients encounter in pregnancy. And if you are worried, this is the most common reference as a medical consultant you will get. We used to get it in the maternal medicine department from in UK as well as in India. So this please remember like that. What is the features like pruritus of most commonly in the palm and the soles usually will happen. There will be no rashes. Please remember this point. There will be no rashes, but there will be some skin changes will be there because of the continuous scratching, and there will be raised bilirubin. How do you manage it? Very simple. Mostly conservative management. Urodioxycholic acid used to make symptomatic relief. Weekly liver function test you have to do, and maybe after 37 weeks you have to induce the liver. Why? This is one most common point you have to do. ICP sometimes increase the rate of stillbirth, and it is also is one of the quality indicator, but it's not generally associated with the maternal mortality. So it is not harmful for the mother, but it's maybe harmful for the baby, and that's why we have to be very careful about it. So this is one point. Now next we move to the next of it, acute fatty liver of pregnancy. This is most rare and most common in exam. So it is more rare complications, but with the exam, the MRCP has a pattern. They will ask you question of the rarest complication so that you will be aware of it. So this is most rare in real life, but most common in exam. So basically, this also all this problem basically seen this in third trimester or even immediately after following the delivery. Again, important point. Please remember, don't get confused if they ask you similar kind of picture and it's happening after the delivery. So you have to remember its mind. What are the symptoms? Abdominal pain, nausea, vomiting, headache, jaundice, hypoglycemia, and sometimes it's having preeclampsia, very non-specific. The ALT usually elevated up to 500, and the management is simple, like supportive care. And once the diagnosis delivered confirmed, you have to deliver the patient based on the patient's gestational age. So acute fatty liver of pregnancy, you will get definitely questions, and this is very common in part one. So be ready for that. One points I wanted to highlight you, and you will get different questions, that all this Gilbert syndrome and Joubin-Johnson syndrome are get exaggerated in the pregnancy, in a pregnant lady. So please remember. Now comes most commonly encountered in exam and most commonly discussed among the students and the trainees is HELP syndrome. That is the hemolysis, elevated liver enzyme, and low platelets. What is HELP syndrome? As I its name is the self-explanation. It's a very severe form of preeclampsia, and it associated with all these points which I just mentioned. It's almost 10 to 15% preeclampsia patients will have like this kind of a. This is quietly discussed and famous because of its mortality rate. It's almost 25% mortality, and basically mortality is happened because of cerebral hemorrhage and the DIC. How do you differentiate DIC and HELP? You can't do. It's very difficult to differentiate in bedside, and you will basically in a pregnant lady rather you always suspect for the DIC, and we always go. There is a lot of overlapping. Is there both etiological and physiological? It is they basically in bedside very difficult to differentiate. The treatment will be symptomatic, supportive, and delivery of the baby. This is the main thing. So this is this about the this ends the story about the HELP syndrome. From the GI, we'll move it to little bit of infections. So this is very common, like 28 weeks gestation lady with a pregnant lady with have a chronic hepatitis B. Most appropriate management strategy for newborn to reduce the vertical transmission. So this will discuss that you have to give the complete vaccine along with the hepatitis B immunoglobulin. Next is that you have that for the ages, this is the most common questions always uh, uh, favorite for the MRCP, particularly in part one, and also sometime in part two in different way, that chicken pox in pregnant lady. And we have to, they will always make sure that you will know each steps, that whether you're sure how to treat and all. Please remember this part. So if you're unsure of the immunity, what is the most appropriate steps of this management? Okay. You have to check for the varicella antibody status of that, what is the previous step. And for the HIV, again, I myself is discussed in ID that details about the HIV managements and all. In pregnancy, I will tell you what is the particular points and the drug therapy of the HIV. It is, we are not supposed to know each detail in depth of the HIV management in pregnant, that we have to understand that for the exam purpose, we will know that what are the silent points we have to keep and certain question oriented points. This will be maybe differ from the our subcontinent or Southeast Asia or Indian scenario, but it is basically for the England's how we are going to manage it. So if this HIV patient 36 weeks pregnancy, her viral load is 45 copies per minute, what is the mode of delivery and what is the precaution should be taken? So you have to do that. There is no superiority of cesarean section over the vaginal section. So we will discuss one and few more things. So let's start with the hepatitis B in a pregnancy. So all pregnant offered a hepatitis B screening in England, and this has to be done irrespective of previously it was done or not. The babies which is born from the chronically infected hepatitis B patients, or they who are acutely have hepatitis B during pregnancy, should receive the complete course of vaccination and hepatitis B immunoglobulin. Very important point. They have to receive not only the vaccine complete full, but also the you have to full immunoglobulin, and this you have to keep it in very mind. There are also some studies is going on the oral antiretroviral therapy, but the later part of the pregnancy. This is just to make you aware of it, but usually questions will not come to make you confusion. They will be straightforward. These questions will be there. There are little evidence suggested that cesarean section reduce the vertical transmission. So please understand that vaginal delivery is always preferred. There is no role for superior that you have to do for the cesarean sections. And please remember that cannot be transmitted through breast milk, and you can breastfeed the patient. In a hepatitis B, mother can breastfeed the baby. An important point, and question has been multiple times asked. Remember, HIV, you cannot breastfeed patients. The guidelines in UK is very clear about that. The HIV mother cannot breastfeed her baby. And this is the important point. Now, when I'm discussing hepatitis B, I also wanted to put empathize, which is very common. Prevalence is very high in pregnant lady. The mortality is very high. That is hepatitis E, which is always behave like a hepatitis E. That is basically come in the fecal-oral route. It's RNA virus. It's almost incubation period is 3 to 8 weeks, and it's common in Asia and Southeast Asia, North, West Africa, and Mexico, like that way. The similar episodes, the disease is hepatitis A, but its mortality is quite high, almost 20%. Does not, it is not become a chronic disease or increase, it does not cause any disease of chronicity, or there is increased risk of hepatocellular carcinoma. Some vaccines are recently has been planned for develop, but these are not yet come into actions, that probably these questions will not come. So please remember, hepatitis E is very common in a pregnant lady if they travel with some areas. This I'm sure you know by this time there will be some geographical questions will come in MRCP to understand that which area patients are coming. If a pregnant lady coming in Southeast Asia develop jaundice, if the hepatitis E is there, please try to understand. The answer will be always hepatitis E. One more point I wanted to mention when I are discussing the some infection in the pregnancy, it is bacterial vaginosis. This is equally important because this increases the risk of preterm labor and low birth weight in the pregnancy and chorioamniotics and late miscarriage. So all this important, it's increase the risk of preterm labor, low birth weight, chorioamniotics, and late miscarriage. So very important like that. Previously, we used to think that, okay, you have to avoid the oral metronidazole in first trimester and the topical clindamycin usually use. But nowadays, they are telling that you can use the oral metronidazole in throughout the pregnancy, though the BNF still against the dose of high dose of metronidazole. Now, this is the confusion. So, but in particularly in MRCP question, they will ask you that can we give the low dose metronidazole? They will specifically mention this like that way. You don't have to go in detail like whether this is there or high dose or low dose. They specifically will mention this. Please remember, these are called clue cells, and you have to be very careful about that. This is particularly common in part 2. And the question for pictorial question, they will ask in a pregnant lady, this kind of vaginal discharge is showing that what it is. If you get, they'll be showing very classical picture. If you get this kind of thing, this is a clue cell and you have to mark the bacterial vaginosis. Now come most common and most...
Sir, excuse me.
Please.
Excuse me, sir. Sir, how long will you give the metronidazole orally?
So this is again the debatable. Usually they will say that 10 days to 14 days, like that way. But there are a lot of guidelines based on individuals. I particularly didn't put that one because usually this they will not ask you in the questions because these are basically discussed in the maternal medicine. And there are a lot of guidelines there that we have to check it once starting. After that, how is it going? After 2 weeks, what is the recommendation? The recommendations are very complicated, and this is basically deal with the ID and the maternal medicine. So, but this will not come in the exam that how long that transition should be there. For your knowledge purpose, if you are going to practice in Indian subcontinent or the continent in Southeast Asia, we used to tell 2 weeks and then come and follow it up like that. Is that making sense to you? Yeah. Yeah, no problem. So we'll move it to the next topic, which is called chicken pox or shingles. So the shingles is always go for the varicella zoster, and there's a lot of nowadays in every specialty, we intensive care, we always get this shingles vaccine and a lot of discussion on that. So shingles is not only now common in West or UK, it is nowadays becoming because of awareness in India also, and we are moving towards to vaccinate all of them. Okay. So keeping that that in your mind, you remember shingles basically stay in the DRG, the dorsal root ganglia, which is a dormant thing, and it get reactivate. Either they can get either directly activated or they can get deactivated like that. There is always a risk to both the mother and the fetus also. So the mother will get more prone for pneumonitis, and they are more 5 times more improvement. So most risk for the mother is for the pneumonitis, and always the fetus is for fetal varicella syndrome will come 1-1. So if the fetal varicella syndrome basically is happen if basically is happen before 20 weeks of pregnancy, the risk is almost around 1%. If it's happening 20 to 20 weeks, there is very small number of chance is there patient will get infected. If it is happening after 20 weeks of pregnancy, chances are very less. But this remain the favorite for examiners and students to ask questions, as because this is not very uncommon to get varicella, though the complication is very rare, but you have to know it in detail in right exam and day-to-day practice to practice. So what are the features of varicella vitus syndrome? They will have a skin scarring, eye defect, microphthalmia, limb hypoplasia, microcephaly, and learning disabilities. So this is a very, because we are dealing with the two lives, one mother and one fetus. Though, as I told you, that mother is our patient, fetus not yet born, so it is not yet our patients, but we have to treat both very carefully. So there also risk is that there is shingles can happen in infancy if the patient mother have the varicella zoster in second or third trimester. The risk is quite high. It's almost 1 to 2%. And severe neonatal varicella can also happen. Patient if the baby get delivered before the rash develop 5 days before or 2 days after the rash. If it is happening in this period, this is the baby will get exposed to that and they will develop severe varicella during that period. The risk is quite high, that is almost 20%. Now, this is the symptoms. How do you manage it? And the please listen carefully. The questions has been multiple times asked that you are not aware of it, the patient's or mother's previous exposure to varicella. Or what should we do? Immediately, you have to mark if it is that, check the varicella antibody of the mother. And this is the answer for that. Urgently have to check for that. If the patient is not immune, you should give the varicella zoster immunoglobulin as soon as possible. The Royal College of Physicians has suspected you and recommended that you can give up to 10 days of post exposure, not like HIV within 72 hours. You can go up to 10 days of post exposure. So just repeat, if you get a mother, don't know the status, check the antibody. Once it is not immune, you have to give IVIG, immunoglobulin. And if your immunoglobulin has to be given up to 10 days. This is the exposure prophylaxis. How do you manage the treatment, the drug therapy? If a pregnant woman develops chicken pox in pregnancy, then you have to always have the ID, infectious disease specialist advice. This is the important points. They will always ask you that, always seek for opinions. This is questions can sometimes ask previously different way in little older questions like that. If you have a serious infection, like a maternal risk is quite high, fetal risk is quite high, then you have to give the acyclovir, explaining the mother about the pros and cons of acyclovir. If there is suggested that the mother is mother is developed the chickenpox after 20 weeks and presented within the 24 hours of the rash, you have to give the oral acyclovir. If they develop less than 20 weeks, you have to give it with caution and discuss with different specialists. Please remember this thing. So everywhere the 20 weeks, the magic. Before 20 weeks, you have to be very cautious. After 20 weeks, within 24 hours, you have to give oral acyclovir. And this question has been multiple times asked. And please remember, you have to mark it very carefully. Do not get any confusion on that. It's very easy if you remember carefully. Now, from that, if we are doing with the chicken pox, how can rubella is far away? Rubella is usually known as a German measles, but is caused by the Toga virus. Nowadays, because of the MMR vaccine, it is very rare, and if it is very rare, it has to be come in the questions very frequently. So the pregnancy is a risk factor for having congenital rubella syndrome, which is very rare, as I told you, and but it will definitely sometime come in the questions because still it is remain favorite for them. The incubation period to 2 to 3 weeks, and infection usually happen before 7 days of symptoms and 4 days after the rash. Please remember these points carefully. For the risk factors, it is damage to fetus almost 90%. This there, and after 16 weeks, the fetal damages are very, very rare. So 8 to 10 weeks first, we are in the risk. What are the features of congenital rubella syndrome? Sensory neural deafness,
Sir,
congenital cataract. Yes.
can you go a bit slow?
For what?
I'm not following everything what you're telling. Can you go a little bit slow?
For the pace the way I'm teaching.
Yes.
I'm not understanding. Can you repeat yourself and in proper English?
Sir, can you go a little bit?
You don't have to shout. I can hear you. You don't have to shout. I can hear you. Like that way. Tell me, you want me to go a little slow, is it? I
Yes.
got the point.
Yes.
Yeah. So that when you are going for the patients in the congenital rubella syndrome, they are basically for sensory neural deafness. I'll request everybody, you wanted to go slow, fast, please put in the message. If you keep in between like that way, I'll not able to complete the class. I'll be highly appreciate all of you that if you put a message in the group. Thank you. So as I was telling like that the congenital rubella syndrome is always happening 8 to 10 weeks. Risk of the damage is quite high if it is coming 8 to 10 weeks, and the damage is rare after the 16 weeks. So if it is okay, we'll move it to the next. That what all the symptoms is happening. That like it caused like a sensor neural deafness. Congenital. Can you switch off the sound? I am not able to follow it up. We should need some decorum in the room.
Not audible, sir.
One minute. Yeah. So, as I was telling you that it has to be the sensory neural deafness, congenital cataract, congenital heart disease, growth retardation, hepatosplenomegaly, pruritic skin lesions, salt pepper chorioretinitis, and microencephaly and cerebral palsy. So these are the most common features which you get in the patient of congenital rubella syndrome, like that way. So these are the thing you have to know. This is very common. You will be wondering and raising your eyebrows that why pediatric symptoms are coming in MRCP internal medicine questions. But these are the questions the examiner will expect you to know, because sometimes they will ask from this kind of symptoms that whether you are getting or not. This is basically part 1 questions and very commonly asked. Now, how do you diagnose this? So, as I told you, this is a notifiable disease. You have to notify the normal agency, and you have to see the IgM antibody, which is recently exposed or not. We have to check for the IgM antibody. And it's also difficult, the patient to distinguish between parvovirus and the rubella virus. So you have to be very important, check that whether the patient is previously infected with parvovirus or not. So few points like diagnostic, basically you have to go for IgM antibody, and that is the main thing. The management. How do you manage it? There is no longer to check for all the patients rubella antibody immunity is a booked case, because all these patients must have been reviewed MMR. So this is not has to be not checked, and this is important points because questions has multiple times asked in this way. And if there is non-immune mothers which is coming, you have to give the MMR vaccine. But if it is coming in the postnatal period, it should not be answered to the pregnant or attempt to give the pregnant. If the patient, so what does it mean? You are still confused. let me tell you again, like that. If the patient is non-immune in a postnatal period, should not be administered or MMR vaccine should not be administered in a patient who are pregnant or not to be pregnant. So it there is all the there is no management. Basically, it is also have that this is a conservative management. The only point is that if you are suspecting a patient, you should not give the patient in MMR vaccine that point of time. Okay. If that is clear, we'll move it to the HIV in pregnancy. Again, I will tell you, you will find out a lot of differences in HIV. This class is beyond the scope that I will discuss everything about the HIV and pregnancy. I am going to discuss about few points which is come in the exam. And it is very important things which you have to know regarding the management. They are not expecting your knowledge to know every antiretroviral therapy in pregnancy, but they has to know that what all things you have to basically knows that when to suspect start IV infusion, what all things you have to do, explain to the patient's family. And this is equally important. Not only part 1 and part 2 is also come in the PACES exams also. Now, all of you know that this HIV infections, when you're coming to the mother, there are 4 points you have to remember very carefully. One is the maternal antiretroviral therapy. What is the mode of delivery you are going to do? What is the antiretroviral therapy you are going to give it to the baby, and whether you are going to feed the baby or not. As I mentioned you previously, that in hepatitis B you should not feed the baby, but in HIV, sorry, in hepatitis B you should feed the baby, but in HIV you should not feed the baby. That is the most important differential point. Let's start with the screening. NICE has recommended every pregnant lady has to be screened for HIV. It has to be, every pregnant lady has to be screened for HIV. And irrespective whether previously screening done or not, the moment you come in the book, you have to screen the patient. If the patients are coming to be positive, irrespective or whether they were taking previously not, they has to offer antiretroviral therapy. This is one more second point. Always remember, vaginal delivery has been recommended if the viral load is less than 50 ml per copies per ml at 36 weeks. So if you remember my questions, I make it 35. So less than 35. 35 was there, and you have to go for the vaginal delivery. So these are the important number. Please remember 50 copies per ml at 36 weeks is the criteria for having vaginal delivery. Otherwise, you have to go for the cesarean section. And you have to go for zudovudine infusion 4 hours before beginning of cesarean section. So zudovudine has to be started as an infusion 4 hours before the cesarean section. And what do you see about how you take care of the baby? As soon as the baby was born, you have to give zudovudine orally if the maternal viral load is less than 50. If the maternal viral load is more than 50, you have to start triple ART. This triple ART and have to continue for 4 to 6 weeks. Triple ART could be anything, and that you are supposed not to know for your level, like that way. You only have to know that there is a triple ART, and this is most important. All these points has been asked multiple times in part 1 and part 2 questions in different ways. So please understand that. And in feeding, it advised not to breastfeed. So very important point. It has that infant feeding has not to be done in HIV patients. So these are the silent points which is very particular about the HIV infection in a pregnancy. Apart from that, normal HIV, which I have taken class, you can go through it about that. One more important points, and we all of you jump together, like antiphospholipid syndrome. Again, this is it's not very uncommon, but yes, we get these patients very frequently, and we also get these questions very commonly in exam. So can anybody tell that which trimester antiphospholipid syndrome cause pregnancy loss? Okay. So that
First trimester. First
what is the
trimester,
most
sir?
What is the most common cause of first trimester pregnancy loss? So first trimester
That is
pregnancy loss, most common cause is genetic disorder. First trimester most common cause. Second trimester most common cause is anatomical disturbance. And third trimester most common cause is one of this is autoimmune disease that can be antiphospholipid syndrome. I told you very gist. There are a lot of in-betweens is there like that way. So that's please remember if you recurrent 2 to 3 pregnancy lost in the third trimester, there recurrent loss usually mostly seen in antiphospholipid syndrome APLA. So we have to remember like that. So this is the acquired disorder mostly. It can cause both venous as well as arterial thrombosis like that way, and it causes the recurrent fetal loss and thrombocytopenia. Very important points. Like it can cause both venous and arterial thrombosis and recurrent fetal loss and thrombocytopenia. It could be a primary disorder or it could be a secondary to some autoimmune disease, predominantly SLE. So antiphospholipid could be primary. Please switch off your mic. I don't want to listen your noisy while taking class. So please, it could be primary, it could be secondary conditions. Most commonly, it can happen in the SLE also. So as I mentioned you that it could be recurrent miscarriage, it could be IUGR, it can cause preeclampsia, placental abruptio, preterm lavatory, and it can cause venous thromboembolism. Very important points. It can cause recurrent venous thromboembolism. This is very, very important things you have to know about the SL. And for the exam thing, you have to know that there is low dose aspirin. Somebody put a message, I saw what is low dose metronidazole. It's 200 mg, like that way. Same time, what is the low dose of aspirin? It is 50 mg. Usually 50 mg should be once the pregnancy is confirmed. We usually not get 50 mg aspirin in India. This is basically NHS. So we'll usually India will get 75 mg when usually give pregnancy, and we have to give the low molecular weight heparin once the fetal heart sound it's heard. So when you get the fetal heart sound, the fetal activity in the ultrasound, we have to start the low molecular weight heparin, and you have to continue up to the 34 weeks of gestation. This is also increased the live birth rate almost 7 folds, and these points are equally important because this has been asked multiple times in part 1 questions. So please remember antiphospholipid syndrome is one of the important questions in maternal medicine. Let's move it to the thyroid. Give me a moment. Yes. So this 30 years old man or woman, whatever it is, came with hypothyroidism, become pregnant. Sorry, men cannot be pregnant. So 30 years old woman is hypothyroidism, become a pregnant. She is on levothyroxine 100 mics. What is the most appropriate adjustment of her medication during the pregnancy? So the pregnancy will increase the thyroid hormone demand. Equally important. We'll discuss as the times. The 28 years old pregnant woman is diagnosed with have a hyperthyroidism in her first trimester. An endocrinologist decided to start treatment. What is the most common drug has to be given in which trimester, and what is the different rationale behind? So we have to start propyl thiouracil first and then move it to the next, the carbamazole after the first trimester over. That why we'll discuss when I'm going to discuss the questions. A lady with hypothyroidism advised to taking levothyroxine with certain supplement. Which supplement should be separated at least 4 hours from the levothyroxine, and what is the reason? Calcium carbonate and iron to reduce the absorption. This all the questions I have collected different from form of MRCPs that make you understand that these are the model type of question usually we'll get it. So the hypothyroidism management. What are the key? So everybody, all of you know that basic teaching that you have to start for levothyroxine and should be lower in the elderly people because they will have the most chances of ischemic stroke and heart diseases. Usually, that patient with cardiac disease and severe hypothyroidism or patients over 50 years, initially they will recommend to start 25 mics and then slowly titrate it up to the 50 to 100. And in other patients less than 50 years, you have to go for 50 to 100 based on your patient's TSH values. The following changes to be done after the 8 to 12 weeks, you have to repeat the thyroid function test. And based on the normalization of thyroid TSH value, you have to adjust the dose. The values thyroid is 0.5 to 2.5, and this has to be aimed in this range after 8 to 12 weeks. Please remember all these points are very, very important like that. So in women who get pregnant, the dose has to be increased at least 25 to 50 microgram thyroxine because there is an increased demand of thyroid hormone during pregnancy. And very important points which you have to remember. Please remember, when the lady get pregnant, the dose has to be increased by 25 to 50 microgram levothyroxine. And it should be monitored very carefully because otherwise you will have neonatal hypothyroid syndrome. And this is very, very important to keep it like always. TSH has to keep it in low normal value. If you listen to my physiology class, I mentioned you the thyroid value, TSH values are not normal in a pregnant lady and the normal individual. It has to be much more lower. So in thyroid, you have to be very much low normal value have to be targeted when you are treating a patient with hypothyroidism. Now, what are the side effects? It can go to hyperthyroid. It can reduce the bone mineral density. It can cause AF, atrial fibrillation, and it can worsen the angina. So very important points. This you have to keep it in back of in your mind. What are the interaction? That's why particularly I mentioned it, that it has to be, remember that iron and calcium carbonate cannot be given and is given at least 4 hours apart because that will help you to lack of absorption. So the few silent points, please remember that you have to repeat the TSH after 8 to 12 weeks. In pregnancy, you have to keep it in 8 to 12, little low normal, and this have to keep it in back of your mind. Now, in pregnancy, when you are going to treat, there is be always increased level of total thyroid binding globulin, and this increase the total thyroxine. The T3, T4 level will be high, but free T3, T4 level will be low or high based on the what disease you are going to treat. But you remember, because of the thyroid bind globulin will be high, it will be always not check the free T3, T4 level. Let's discuss the thyrotoxicosis. Thyrotoxicosis is very important things in pregnancy, and there is increased risk of fetal loss and maternal heart failure and premature labor. All those things can cause in thyrotoxicosis, particularly in pregnancy. I'm not discussing thyrotoxicosis in detail. And the Graves' disease is most common cause of thyrotoxicosis in pregnancy. This also remember like that the beta HCG has activated the TSH receptor because both are almost similar kind of property. And this is that transiently there will be always a gestational hyperthyroidism. That's what we always tell that you have to be very careful about when measuring TSH in a pregnancy because the TSH receptor will always get activated by the beta HCG. But after the second and third trimester, when the beta HCG level fall down, you have to be very carefully that time titrate the thyroid medication dose. Management. I am not going to the what is traditionally used, plus for exam purpose, you remember, the propyl thyroxine is a drug of choice in initially first trimester. And then when it come to the second trimester, you'd have to switch to carbamazole. So first trimester, propylthiouracil. Second trimester, come back to carbimazole. Why? Because propylthiouracil has associated with more, the carbimazole is associated with more risk of congenital abnormality if you are using in first trimester. Later one is more increasing for the hepatic injury, severe injury if you are using in the later part of the trimester. So first trimester, propylthiouracil, because it can cause it can has minimal effect of congenital abnormality. We cannot use the carbimazole because it can cause more congenital abnormality. Second trimester onwards, you can go back to carbimazole, and because we cannot use propylthiouracil because it can cause severe hepatic injury. This is the important points you have to understand like that. The maternal free thyroxine level should be kept upper third of the normal reference to avoid fetal hypothyroidism. Very important point. Upper third, upper one third of the normal reference. This is the important raise. You have to keep it in back of your mind because question has been multiple times asked on this way. No block and replace regime should not be used. Very important point, and question has been asked often. Radioiodine is contraindicated. Very obvious reason. You don't have to need Rockenstein to understand that. And you have to thyrotropin stimulating hormone antibody. It has to be checked to determine whether the patient fetus will develop neonatal thyroid problem or not. That's all. Regarding the hypothyroidism, I already explained you that when you're going to do. Only one point, breastfeeding is safe when your patient is on thyroxine. So patient is on thyroxine, you can breastfeed the mother. This is the basic difference when you're going to treat a pregnant lady with hypo or hyperthyroidism. I just briefed you. And also I told you that what all the values you have to understand, that what all the values you have to keep like that one or second. Now we'll move to the next topic, like a migraine. Very important topic, and we'll very commonly get migraine in pregnancy, contraception, all these hormonal factors, which is actually precipitated. The migraine is precipitated during pregnancy. Please remember, if you are getting migraine first time in life in pregnancy, it is not migraine. That is the rule of thumb. If you have a history of migraine which is worsening during pregnancy, it is a migraine. Do not diagnose migraine first time if you are getting migraine during pregnancy. It should be something else. What is the drug of choice? Is paracetamol. You can give the NSAIDs in the second and third trimester if you are going to treat the patients. And please remember, aspirin and opioids is avoided during pregnancy when you are treating migraine. Except you have to use it if you are getting APLA, but not when using the migraine. Aspirin is avoided. If you are getting migraine with aura, and you should avoid completely oral contraceptive pills because there is increased risk of strokes are there. So if you are getting a migraine with aura, OCPs are completely avoided. If you are getting a pregnant lady during menstruation severity, then we have to treat with mefenamic acid and combination of aspirin, paracetamol, and caffeine. It's also sometimes triptan you can use it. So please remember, the drug of choice initially, if you are getting migraine during menstruation, which is very common because many of the patients, they'll increase migraine during menstruation, this you have to use mefenamic acid. Otherwise, you have to go for aspirin, paracetamol, and caffeine. Migraine with HRT, yes. Safe to prescribe HRT migraine, but if some HRT you prescribe, sometimes migraine get worse. And you have to be very careful if you're prescribing HRT in a migraine which is having migraine aura, they're also prone to develop strokes. So we'll come to that now. Excuse me for a minute. Yeah. So very important, like as I told you initially, like when this pregnant lady will get a epilepsy and patient is in sodium valproate, what is the most appropriate steps to minimize the fetus? So you have to understand which all are causing patients having congenital malformation, which all drugs are not causing malformation, or which are the least causing malformation. And if the breastfeeding mother on lamotrigine, what is the safety of the medication? What advice you should give for a patient as an anti-epileptic drug? So these few points, silent points, you have to know. Pregnant lady who is on epilepsy, who is having pregnancy. Let's start one by one. The pregnant lady, with first of all, you have to understand that the pregnancy may generally having this two, always the pregnant anti-epileptic does AEDs having lot of risk of malformation in the fetus. But this is not like you have to stop the medication during pregnancy. We have to start the least teratogenic drug which is causing, because the safety of the mother is most important rather than the congenital abnormality in the fetus. This is the main mantra of treating patients in the maternal medicine, as I keep telling you from the first. So that should be advised that all patients should take folic acid when they are planning for pregnancy who are previous history of epilepsy. So folic acid 5 mg should be started well before when you are planning for pregnancy. This will minimize the neural defect. So there are 1 to 2% of newborn which is born to the non-epileptic have congenital defect, where there is a marginal rise of the pregnant congenital abnormality in the pregnant mother who have epilepsy history. So 1 to 2%, which is 3 to 4%. Please remember these numbers. This is equally important. What are all the other points you have to treat? Keep it in your back of your mind that you have to keep for the monotherapy. There is no indication of monitor the anti-epileptic drugs level. And most important, multiple times they'll ask you that sodium valproate has to be stopped because it can cause neural tube defect. Carbamazepine supposed to be least teratogenic of the older antiepileptics and equally important. Phenytoin, its cleft palate, completely banned. Lamotrigine, at showing rate of congenital malformation is very, very low. And so lamotrigine needs to be increased. The lamotrigine has pregnant congenital abnormalities, lows are very, very low. But 1 point, the dose has to be increased during pregnancy. So sodium valproate out, phenytoin out, carbamazepine if in options and lamotrigine is there in the option, mark for lamotrigine. If carbamazepine only their option, mark for carbamazepine. Lamotrigine in pregnancy taking, what is the advice or exam? You have to increase the dose. Please search for these points because an exam will not have that much time to understand that. And the breastfeeding is not a unsafe option in antiepileptics, with possibility that only if a patient is in barbiturate, that can be extended to breastfeeding. And if the patient is taking phenytoin, they are advised to take vitamin K last week of pregnancy to prevent have some clotting disorder in newborns. Please remember this point because it has come multiple times in part 1 that if the patient is in phenytoin, they has to be advised in vitamin K in last month of pregnancy. And as I told you, sodium valproate is completely avoidable because of the neural tube defect. So the gist is carbamazepine or lamotrigine. Lamotrigine is least, nothing is zero. Carbamazepine and it's least teratogenic. Another more than that is lamotrigine, but it has to increase the dose in pregnancy. That's all. You have to remember these points when treating pregnancy. Now, the most few points I have taken it like to understand some rheumatological disorder which is get flare up or get better both the way during the pregnancy. What all they? Let's discuss one by one. Okay. So first thing is that the SLE. So the maternal antibodies usually cross the placenta and it can cause the neonatal lupus syndrome. So very important, please remember this point. This can also cause the congenital heart block, and which is anti-Rho SS antibody has to be the diagnosis. These all the 3-4 points are very important. So anti-Rho SS antibody, SSA antibody is the diagnosis of congenital heart block because of the SLE. Let's move to the rheumatoid arthritis. How are you going to treat it? Basically, All RA is happen in patient in the reproductive age group, and therefore it is most commonly we'll see in the reproductive age group. But there are no consensus guideline, not from the Rheumatological Society or not for the RCP and NICE, that how to manage. There are some expert reviews are there, which we have to discuss, and that's why they will ask you the questions. So please remember, patient with poorly controlled RA should be advised to control the disease before getting pregnant. This is the basic funda. You have to keep it in back of in your mind. The RA symptoms either you'll improve or resolve completely in some group of patients. But after the delivery, it will get flare up. And this is very important point to have to remember. The RA either will get better or gets completely resolved, but after pregnancy, it gets more exaggerated. You can't give methotrexate, simple logical reason, and it has to be stopped 6 months before you are going to get pregnant. Leflunomide, it's not safe. The only safe is sulfasalazine and hydroxychloroquine. This is the hydroxychloroquine and sulfasalazine is very safe in pregnancy. There are also some people look into it TNF alpha, but that doesn't show any significant increase in adverse outcome. But some patients has to be have found they were in pregnant. There are some studies are showing that they were having some issues in that. So basically, sulfasalazine and hydroxychloroquine is that TNF alpha is also not very safe. Low dose corticosteroid used to have, you can give if the patient to control the acute symptoms if he get exaggerated. Up to 32 weeks, you can use the NSAIDs, and which after that you have to withdraw it. Otherwise, there will be early closure of ductus arteriosus. So very important point. Please remember that up to 32 weeks, you can give the NSAIDs, and after that you have to close it because that will cause the premature closure of ductus arteriosus. And important exam also, always when you are treating a rheumatoid arthritis patient in pregnancy, keep your anesthetic informed because there will be always risk for difficult airway and atlantoaxial subluxation if you are going to resuscitate this kind of patients. It is important. You have to aware of this fact because their spines and the airways are not as common as your normal reproductive age group patients. Move it to the next. And do we get lot of skin disorder in pregnancy? We do get. And we do encounter a lot of people who have a different kind of skin disorder associated with pregnancy. So what all they are? I'll show you a few more things. These things are very important in part 2 questions, and you will commonly get this question, and these are the most common pictures which you will get it. Right? So let's explore one by one. Atopic eruption of pregnancy. This is the most common skin disorder. It typically is eczematous, itchy, and red rashes. There is no treatment required. So this atopic eruption of pregnancy most commonly getting. Please remember all these points because we will be having clinical oriented questions, those who are preparing for part 2 exams. Polymorphic eruption of pregnancy. This is basically seen in last trimester, third trimester. This is how it looks. Please follow these photos. You will have all these areas where you will get this lesions of basically it started in abdominal stria. That's what I marked it here. And then it will move to the legs everywhere. Basically, it depends upon the severity, what you're going to give. Mild severity, you can give steroids. If it is increase, you have to give the oral steroid. And these are the classical picture. Please keep it in your brain so that you will know that the photos come like this. You have to straight away mark for the polymorphic eruption of pregnancy. There are the few more pictures which is classical of polymorphic pregnancy. Please remember. There's something called pemphigoid gestationis. So these are the pruritic blistering lesions which you'll see, and basically you will see in the periumbilical region. and then it can spread. It started with the periumbilical region, and it is sent to the back, buttocks, and arms. Usually seen in second and third trimester, and rarely seen in first trimester. That the mostly common in the second and advanced trimester, and oral corticosteroid is required. These are the pictures, very classical one. As I told you, they'll have the lesions like starting around the umbilicus, and they'll spread all over the body. These are the very classical part 2 questions. Every alternate diet, you will get this kind of question. So please train your brain such a way that you will be able to understand as soon as you see this kind of picture. And the treatment of choice is give the oral steroids. Now, actually, this ends mostly the topic which is supposed to cover in the maternal medicine. There are other topics which some topics I was put in, I have gone through multiple times, like what all the renal diseases in pregnancy and how does it differ from that. With exhaustive research or search, however you called it, I didn't find out that the renal disease per se has difference from the normal renal diseases than in pregnancy. All the disease which you get in normal individual can get in pregnant lady, and they will have the similar kind of management. As I told you, if it's the life saving, we have to save the mother. We don't have to consider the teratogenicity of the pregnancy to withhold any treatment. But obviously, when you come to the treatment where we can balance both, we have to treat considering the teratogenicity of some immunosuppression drugs. Now, few points in a renal medicine which I want to highlight if the patient in pregnancy, the hypertension I've already taken in the class. So, how do you assess the patients and assessment the patient when they are pregnant? So it depends upon that when they get pregnant, what is the degree of renal infarct, and what is the presence of hypertension during the conception or the early pregnancy. As I mentioned it previously, the BP goal is always less than 140 to 80. And it's also the degree of proteinuria. So these are the most important points which you are going to see a pregnant lady. This is, please remember, this are mostly commonly exam on pregnant lady will not get like maternal medicine, but the different kind of questions which a pregnant lady, they'll go through you the renal diseases and then you can go. So please keep your concept a little bit clear. If the patient is mildly impaired renal function, that means the creatinine is less than 125, GFR is around 50 to 70, like that. The live birth rate is almost 95%. So mild renal function is not. If you remember, in the first physiologicals, there will be high blood flow to the kidney. So the renal clearance will be high. So the creatinine value is 0.5 to 0.9 is normal. Anything more than 0.9 is having the mild renal infarct. So please remember those values. There is slightly increase of preterm delivery or preeclampsia or IUGR. This is the seen if the patient is having mild renal function. The pregnancy per se will not worsen the renal function, but you have to be very careful this group of patients. This is the mild. If the creatinine is 125 to 250 millimole per liter, the GFR is around 25 to 50. There is a very increased risk up to 50%. They will develop preeclampsia, fetal growth restrictions, and the preterm delivery. Please remember. If there is a hypertension is not very much controlled with regular medication, or you have not put much attention, there is increased rate of intrafetal death or the neonatal loss. The live birth deaths from 95% to bring to 85% with the if you have done a reasonably good and religious blood pressure control. This is the more thing. And severely impaired renal function, when creatinine is more than 250 millimole, GFR is less than 25, there is high risk of antenatal complications and spontaneous abortion. If there is uncontrolled hypertension, there is almost 10% increase of the neonatal mortality. And live birth is almost fall down to 50%. It depends upon how the management is done. If the patient is in end-stage renal disease, CKD stage 5 of non-oliguric or oliguric on dialysis, the fertility rate is very high. The miscarriage rates are very, very high. Fertility rates is very, very low, and there will be many unsuccessful pregnancies. It also depends upon how you are going to control the blood pressure and what is the plan of your renal transplant. In this group of patients, you have to avoid the MMF because during pregnancy and conception, if you're planning for renal transplant. So this is the one important point in the end-stage renal diseases. What is the management consideration? Nothing much. You have to counsel the patients. You have to explain them all the genetic risk and renal function. You have to do an early antenatal referral. You have to keep all the biochemistry frequent monitoring. You have to be very careful about the BP monitoring. AC inhibitor ARVs are completely out and you have to stop it in early pregnancy. Basically, drug of choice, alpha and beta blocker like levetidol, alpha methyl dopa, or long-acting nifedipine are preferred. So, and you have to do the fetal monitoring very frequently to find out how you're going to manage the patient. This is the normal renal impairment, mild, moderate, severe, or CKD stage 5, how you're going to manage. Specific condition. There is nothing much difference in specific condition. I just put few slides just to make you understand and go through a journey like how you're going to do specifically that the primary glomerulonephritis, what all the challenges you're going to face in your pregnancy, there are more chances of infection, hypertension, proteinuria. These are the basic points just to make highlights like that. If you're an autosomal dominant polycystic kidney disease, you have to always explain the patient clearly and link the renal monitor. If you have a congenital urinary tract infection or obstruction, congenital urinary tract obstruction, you have to do the serial renal function and urine culture frequently. If you have a vasoureteric reflex nephropathy, you have to drain the obstruction before planning for any pregnancy. Diabetic nephropathy, always focus on the glycemic control. Lupus nephritis, always you have to find out that whether it is the preeclampsia which is causing or is the lupus flare up. How do you do that? Always lay for complement level. C3, C4 level will be low. Renal transplant, you have to delay the pregnancy until the graft becomes stabilized. Because if the pregnancy happen early, there are high chance of GVHD, that is graft versus host disease. So these are the basic things we are supposed to know. If you understand the previous, I will go through you few more 2-3 questions before I conclude the class. So this is the lady which have a CKD, present with 8 weeks of gestation, BP was 150/90. He has a baseline serum creatinine of 130 millimole, GFR of 50 millimolar, currently taking ramipril for blood pressure. What is the most appropriate next step of management? Anybody? Anybody can comment? So as I mentioned, you have to stop the ramipril and you have to switch to the labetalol. That is the basic thing. Second part is this 26-year-old pregnant lady who has autosomal dominant polycystic kidney, presented 24 weeks of gestation. Her blood pressure is well controlled with labetalol, but she reports intermittent right flank pain. An ultrasound showed hydronephrosis, no evidence of urinary obstruction. What is the most common next step? So, mild hydronephrosis, you have to keep monitoring the patients, treating with the paracetamol, and there is no evidence of any infection or symptomatic treatment is appropriate. You don't have to treat with antibiotics or anything in this group of patients. 29 years old lupus nephritis, she is predominantly on prednisolone and MMF. Most common appropriate action is regarding the medication. You have to discontinue the MMF and change it to something which is nephrosafe better, that is azotherapy. So this you have to be very careful about it. This 34 years old woman with history of diabetic nephropathy, 12 weeks of pregnant, her HbA1c is 8.5, his urine protein shows significant proteinuria. What is the most common risk to action to reduce the fetal and maternal complications? You have to go for very strict glycemic control. If you remember, I already mentioned last class that how to control glycemic control in a patient with diabetes in pregnancy. Last but not the least, 30 years old woman came with end-stage end-stage renal disease on dialysis, become pregnant. And the chance of having successful pregnancy, what is the most accurate? So the pregnancy outcome is best if the dialysis increase to daily sessions. Very important point. If you remember, usually these patients will have bi-weekly or 3-weekly dialysis, but if they are increase the dialysis frequency, that will make them more susceptible to not to have any pregnancy loss or anything. Now this ends so-called our session for having maternal medicine. We are not done in a detail in discussion like how you are going to do in. So this ends our session that how we are going to deal with the patients which come in the maternal medicine. We are not explain in detail about all the diseases. What you are supposed to know that all these patients who are coming here for having maternal complications has to be taken very carefully according to the physiology and according to the disease status normally. Please remember what all the points difference is there for the pregnant and non-pregnant and the doses and how you are going to do in a patient who is having the pregnancy dose adjustable, and each patient is because based on kidney function and liver function. Every formulas, every disease, like when you are going to treat the patients, in the patient, particularly in the chicken pox, you have to take with patients with go slow and check first the patient with whatever you have for the patient that was previously antibody done or not. Please remember, as I previously keep telling you like that, whether you are writing in part 1 or part 2, read the question, and when you start the question, you get an answer after 1 or 2 lines. See the options, what they're asking, see the last line of question, and then search for the information, what you're going to get it into the questions. And then proceed for the answer. You will have very less time to concentrate on question because one question will be one paragraph. And if you're particularly part 2, one question will be one essay question. So that you have to be very less time to use your brain and you have to use it fast and get the question answer correctly. So do not get carried away from some tricks. Some of the question will be there that though it doesn't carry negative mark all this, there are some formula called standardizations. Some question which they are purposefully ask you that if you miss it, your score on comparison to others will come down. So be careful about the scoring on that part. With that note, I'm going to conclude the class. If any questions anybody have, I would prefer to know in chat box. Thank you.
Sir,
Please.
yes, sir, we are.
Not audible.
Sir, am I audible?
Yes.
I'm saying,
বলুন সুস্মিত।
sir, আপনি এটাতে থাকুন। রাজু স্যার এটাতেই জয়েন করবেন।
হ্যাঁ ঠিক আছে, ওকে, নো প্রবলেম, আপনি ওদের ইয়ে করুন, ঠিক আছে। The students, anybody had any question, they can please put into the group, please.
Sir, I am putting a question in the chat box.
Please. So there is no specific treatment for RA. Like 1 minute. So you cannot give methotrexate. Okay. But the drug of choice will be there, sulfasalazine and hydroxychloroquine. You cannot give leflunomide, you cannot give methotrexate. You have to give sulfasalazine or hydroxychloroquine. And when you always, and you have to, if you are having acute flare-up, then you have to give low-dose corticosteroid. If the patient is having very much burnt out rheumatoid arthritis, you have to control the pain with NSAIDs up to 32 weeks. But after that, you have to withdraw it because there is a risk of early closure of ductus arteriosus. And when you are treating this RA patient, anticipate there are obstructive complication. Always call your obstetric anesthetist because there will be atlantoaxial subluxations, which is very common in long-standing RA. So specifically, if you ask me that what is the questions you are expecting RA in pregnancy, methotrexate contraindicated, leflunomide contraindicated, sulfasalazine and hydroxychloroquine is drug of choice, considered safe.
Okay, sir. Thank you.
My pleasure. Anybody else? Okay, thank you very much. So this was a very easy and short topics. This usually will not cause much to you in comparison to that, but this is a very important things that if you read this part, then you will not miss it. Please, another question. Go ahead. This is little tricky. This will not come you in the MRCP question, but as I told you previously that the most common first trimester is congenital abnormality. Second trimester, I mean, most first trimester is genetic abnormality. Second trimester is anatomical abnormality, and third trimester is autoimmune disease. If you have a list of that is quite exhausted, I will post you in the group. Please collect it like that way. For the exam purpose, this is important. First trimester is not for the APLA. First trimester is most common is the genetic abnormality.
Okay, sir. Thank you. Can you give some summarize these causes? Yeah.
I'll give it to you. I'll give it to you. I'll send it
Thank
to
you,
you.
sir.
We'll so that you that will be. Why I'm not telling you. There's a lot of causes are there. I'll summarize in such a way that will be help you to memorize in exam oriented. It will be easy for you. But this kind of
Yes, sir.
question usually won't come in Royal College exams. But still, I'll give it to you. Don't worry.
Thank you, sir.
Yeah. Anybody else has any question? Please feel free to add. If not, we can conclude.